system. They are kidneys, two kidneys, right kidney, left kidney, ureter, which is the structure taking the urine from the kidney down into the urinary bladder. And the urinary bladder, the job of the urinary bladder is to store the urine as a temporary, and the urethra is the passage for urine from the bladder to come out outside. And for yes, male urinary urethra is also served for the reproductive system. And don't forget the length of the male urethra and the female urethra. That's why female more common for urinary tract infection. And kidneys are supplied by the renal artery and renal vein. And the functions of the kidney, 3E, yeah, excretion, electrolyte and acid-base balance, and endocrine function. The endocrine function of the kidneys involve erythropoietin, which stimulate the bone marrow to produce erythropoiesis, red cell formation. Renin, we will study about renin in later lectures, and hydroxylation of vitamin D to active form vitamin D, so which means like the skin will start the process and the kidney will complete the process to get the vitamin D. So therefore, if we have renal insufficiency, or if we do not have a good kidney, we will have excessive fluid in our body, then we will be edematous, we look bloated, and we have lots of waste products in our body, especially urea. Urea is very irritating to the skin, and the skin will be itchy and scratch. And we will be acidotic because the kidney cannot balance the hydrogen ion, sodium, potassium. Then his hydrogen ion cannot be excreted, and we become more hydrogen ion in our body, and we become more acidotic, and we will be weak because we do not have erythropoietin to stimulate the bone marrow for red blood cell. We do not have vitamin D, so our bones will become softer, osteomalacia. So all the problems we are going to get, and that's our kidney is doing for us. And I want to remind you, the kidneys, red in color, and they derive from the mesodermal tissue, and three structures, ectoderm, mesoderm, and endoderm. Yeah, I believe you remember this already. And so the renal arteries and the extent of the kidneys from thoracic 11 to 12, left kidney is slightly higher, right kidney is slightly lower, and from thoracic 11, 12 to lumbar 2, 3 vertebrae, yeah, depend on the side. And right kidney is lower because of the liver, left kidney is higher because there is no liver. And you remember the kidneys, when we were very little fetus life, they were the pelvic organ. With the growth and development, the kidney gradually go up from the pelvic to the lumbar region. And don't forget the ureters, they are running on the tip of the transverse processes of the lumbar vertebra. And this is the cadaver. Yes, we were with, in real anatomy class, we will be dealing with the cadaver. But on the other hand, you as a student, your next step is to go into the clinical environment, and you will forget about all the cadaver. And what you need to know is you need to know the cross-sectional anatomies and radiological anatomies, because you are in a clinical environment. So just try to remember the kidneys are the retroperitoneal organ, posterior to the peritoneum. They are stacked on the posterior abdominal wall, and you can appreciate this. And kidneys are well supported with the capsule and fat around the kidney just to support it, make it suit to take the shock. And this is the transverse section or cross section on the CT scan, and I hope there is no big difference between this CT scan image and this diagram image. So I want you to have a photographic memory. You know, like everything you see in anatomy is, to some extent, we need to have photographic memory. Only then, you know, from this photographic memory, we can take to the next step. So this, if we remember this, we will remember that. And two kidneys stacked on the posterior abdominal wall. These are the posterior abdominal wall and spinal muscles, which we will talk about that today. And this is the liver and right kidney, left kidney, and renal arteries and renal blood vessels. You can see that. So that's the same, isn't it? And now if you look from the back, the kidneys are pretty low lying, as we know. Thoracic vertebra 11 to lumbar vertebra 2 to 3. So right kidney is lower. So if there is any penetrating injury in the posterior abdominal wall, even below the ribs, we got to be careful with our kidneys. Yeah, kidney can get stabbed, and there can be laceration of the kidneys. And that is a relationship between the kidney, lungs, and the pleura. So a stab or penetrating wound in the posterior abdominal wall is going to damage, if it is deep enough, it's going to damage the deep structures like the pleura or the kidneys or ureter. So, and that's the dimension of the kidney, like, you know, AP diameter is 3 centimeter, the width is 6 centimeter, and the height is 12 centimeter. Of course, it is just wrong. Because why does this size important? Because if someone has a kidney disease, and with the chronic kidney problem, like long-term kidney disease, the kidney's size gradually gets smaller and smaller and smaller, gradually shrink. So which means if you are doing an ultrasound scan, like to the kidney and renal ultrasound, and if you see a small kidney, like which is about like 3 centimeter, 4 centimeter, 6, 7 centimeter height, then you know that this kidney is small. That is not the size of the kidney. That means this patient has chronic kidney problem. So the size is important. And don't forget, like as usual, it has got outer cortex and inner medulla. And look at the blood vessels here, renal artery come in and split as segmental artery and go in between the renal lobes as interlobar artery. And it's just go like an arcuate artery. And from arcuate artery, these vessels go into the cortex as the cortical radiant artery, like a radiation. Yeah, radiation. So you know quite a lot already. This is what we call the hilum. The initial dilated portion of the ureter is called renal pelvis. Yeah, renal hilum is the site, the area where all the blood vessels go in and out, ureter come out. This area is called renal hilum. And we need to study about the corticomedullary junction, because this area, that is the important for us. And then now we will study about the corticomedullary junction. Now you remember the triangular, pyramids, which is in the medulla and outer cortex. And yes, you know this, dialysis machine and renal hilum and renal sinus. Renal sinus is where everything going inside the kidney. Yeah. So what is the big difference between hilum and the sinus? Of course, hilum is the site where all the blood vessels go in, blood vessels come out, and ureter come out. That area is called renal hilum. And on the inside of the kidney, that area is called renal sinus. And the kidneys, like the renal pyramids, we gradually drain into the minor calyces. Minor calyces will gradually flow into the major calyces, and major calyces will gradually enter into the renal pelvis. That is what we see here. The outer cortex, inner medulla. Medulla has got renal pelvis. In between the renal pyramids, we have the partition, which is the continuation of the renal cortex extending into the medulla, which is what we call the renal column. Yeah, renal column and renal pyramids. With the renal column and renal pyramid is called renal lobe. And there are about 10 lobes, like 5 to 10 lobes in each kidney. And these pyramids will drain into the minor calyces. Minor calyces will march together to form the major calyces, and major calyces will drain into the renal pelvis and then finally go into the ureter. So yes, I mean, it's not a big deal about this slide. And arterial system like renal artery go in and then immediately branch into the segmental artery and then go into the interlobar artery and then become like an arcuate cortical radiate artery, arcuate artery, and then finally we go into the cortex as cortical radiate artery. So the hierarchy is 1, 2, 3, 4, 5. Yeah. So that's the gradual division of the renal artery inside the kidney. And of course, the veins we follow the artery. Like if we have renal artery, we have renal vein. If we have segmental artery, we do not have segmental artery. We have the interlobar artery, we have interlobar vein, and arcuate artery, arcuate vein, cortical radiate artery, cortical radiant vein, afferent arteriole. So everything like, like opposite direction, everything is going into the opposite direction. And this renal cortical radiant artery will finally become glomerular arteriole. Yeah, so just before it goes into the glomerular arteriole, and inside the glomerular arteriole, this little blood vessel is called glomerular capillary. And once it comes out from the glomerulus, it is called efferent arteriole and become peritubular capillaries and vasa recta, which we will see their anatomy in detail in later lectures today, and finally become cortical radiate vein, cortical radiate artery, and so on and on and on. So what we need to understand now is we need to understand the afferent arteriole, glomerular capillaries, and efferent arteriole. For us to understand this, we need to understand the nephron. Yeah, so nephron, which is equivalent to the neuron, yeah, or osteon. So this is the functional unit of the kidney. So kidney is nothing without nephron. The brain is nothing without neuron. The bone is nothing without osteon. Yeah, and the skeletal muscle is nothing without sarcomere. So these are the functional units of the systems. Yeah, so nervous system, the functional unit is neuron. Neuron is the walking horse for the nervous system. The sarcomere is the walking horse for the striated muscle, and osteon is the workhorse for the bone. Of course, it's in the compact bone, and the nephron is the workhorse for the kidney. So without nephron, the kidney is no meaning. Yeah. So now we have to study the nephron. Nephron, yes, like as we know, like we have the cortical radiate artery. From a cortical radiate artery, a little branch came out as the afferent arteriole, afferent coming in and go into the glomerulus or glomerular capsule and leave as the efferent arteriole. So I have been talking nephron, 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 and what do I mean by nephron? Of course, nephron has two main portions. I hope you remember that nephron has two main portions. Number one portion is the cap, the little cap here, which is what we call glomerular capsule or Bowman's capsule. That is the capsule. And inside that, there is a capillary. That is what we call glomerular capillary. Yeah. So glomerular capillary and glomerular capsule is one. And the tubular portion, renal tubule, that is two. So a nephron is made of, nephron consists of two portions. Number one, tubular portion, and number two, glomerular portion. Glomerular portion consists of glomerular capillary and glomerular capsule, which is also called Bowman's capsule. So that is the nephron. Glomerular capillary and glomerular capsule is one portion, and the tubular portion. Combination of both is called nephron. Yeah, so nephron consists of glomerular capillary and glomerular capsule. In combination, they are called renal corpuscle. This terminology is a little bit important. I want you to grab it. So glomerular capillary and glomerular capsule combination is called renal corpuscle. Renal corpuscle and the tubular structure, which is the renal tubules. The renal tubular structure start with the proximal convoluted tubule, distal convoluted tubule, loop of Henle, and collecting ducts. So this is what I've drawn here. Not very nice diagram. So efferent arteriole, glomerular capillaries, and leave the glomerular renal corpuscle as a efferent arteriole, and this loop of capillary is going to invaginate into the tubular portion and Bowman's capsule. And then we start with the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and finally they will all drain into the collecting duct. So yes, this anatomy, like the capillary and glomerular Bowman's capsule anatomy, is a little bit important for the sake of anatomy, because you are an anatomy student, you are an anatomist. So you need to behave, you need to think, you need to act, and you need to have a knowledge as an anatomist. And therefore, yes, we will just go and study a little bit there. So if you think about that, this efferent arteriole can become the capillary, and so glomerular capillary and efferent arteriole. So if you push this glomerular capillary into the Bowman's capsule, then this is what we are going to get. Yeah. And of course, we lost the one layer. It's because we said renal corpuscle is made of Bowman's capsule, which is this one, and the glomerular capillary. So this is the Bowman's capsule, and this is the glomerular capillary. So that is the layer. So therefore, in that region, Bowman's capsule, we have two layers. Yeah. Number one is that portion which directly attached to the capillary, which is called visceral layer, and the outer covering layer of the Bowman's capsule, which is the parietal layer. And as you remember, the parietal layer is made of flat, simple, squamous epithelium. It's just something flat. But this visceral layer, hey, we don't even have a cell in the visceral layer. What do we have? We do have podocyte. Podocyte is something we have seen in the capillary. So that's, that's the glomerular filtration region anatomy. So glomerular capsule parietal layer is fat, simple, only one layer, squamous, flat epithelium, and the glomerular visceral layer is just made of podocyte, yeah, just made of podocyte. So on one side, we have the lining of the capillary, which is the endothelial epithelium. On other side, on opposite side, we have the podocyte, which is like an octopus. And in between these two, we have a basement membrane. Basement membrane, yeah, of course, this endothelium has to rest on. Endothelium is the simple squamous epithelium, isn't it? It is a epithelial tissue, so it needs to rest on the underlying connective tissue, which is the basement membrane. So that is the filtration layer. From one side, we have blood, and from other side, we have the filtration into the kidney to become urine. Yeah, so that is the reminder about the capillary, three capillaries, as you remember: continuous capillary, fenestrated capillary, and sinusoidal capillary in the kidneys, guys. Hey, look at that, look at that, look at that. Kidneys, we are going to use the fenestrated capillaries. Yeah, so that is what we are going to use here. Yeah. And if you look a little bit more detail, you can see the fenestrated capillaries here. These fenestrated capillaries will be surrounded by the podocyte. Look at that big octopussy podocyte here, surrounding a lot of little food processes branching out from the podocytes, which is like trying to filter the blood and just let, like, you know, all the waste will be passed through this layer. So yeah, so in detail, like on one side, this is the capillary side, which we have blood and plasma. And here we have the endothelial cell. Endothelial cell is a flat, simple squamous epithelium, which is lying on the connective tissue, which is the basement membrane. And on the other side, we have podocyte. Yeah, so this is the filtration slit and filtration pores for the blood to filter, and it will go into the glomerular basement membrane and then proximal tubule. Yeah, so that's the filtration process. That is the very, very lovely diagram, which is in our textbook about the podocyte and food processes. And if I can remind you, you know, like kidney artery came into the kidney, afferent arteriole finally became capillary, and leave efferent arteriole, and then finally become renal vein. So one is coming in, one is coming out. So by doing so, they will have some impact on each other, because one is coming down, in and out, in and out, in and out, which means they are not far from each other, and therefore there is some degree of transfer from each other, especially heat. So now we come back to the corticomedullary junction of the kidney. Yeah, on one side we have cortex on this side, and we have medulla on this side. So cortex this side, medulla this side. So this is the cortical portion, and this is the medullary portion. What I want you to remember is this renal corpuscle, like, which is made of Bowman's capsule, glomerular capillary, and glomerular capsule, proximal convoluted tubule, distal convoluted tubule. They are in the cortical portion. Oh my God, that's really important. Yeah, that's really important. And the loop of Henle, like a U loop, it's look like a U. It's look like a U. Loop of Henle extend into the medullary portion. Yeah. So therefore, because of the multiple loop of Henle's, the renal inside the renal pyramids look striated. Yeah. But why does a renal pyramid look striated? Because there are multiple loop of Henle's. Yeah. And then finally, they will drain into the collecting tract. Of course, collecting tract is partly in the cortex and partly in the medulla. Hey, yeah. So that is what we were talking about. And now we will have to slow and steadily study about the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and the collecting tract. Are you down for that? Please say yes. Yeah. So, oh, I have been talking about nearly 30 minutes just for revise. So I hope that way remind you what we have learned on Monday, and then we just progress. Yeah. So hey, from now on, I want you to remember renal corpuscle, proximal convoluted tubule, distal convoluted tubule, and part of the collecting tract is in the cortex. The loop of Henle going vertically, and the collecting tract is in the medulla. Therefore, the medulla, which is in the renal pyramids, they have striations. Yeah. So now let's go and study a little bit detail about the proximal convoluted tubule. Proximal convoluted tubule, of course, it is a tubular structure inside, like esophagus or gastrointestinal tract or ureter, any tubular structure inside, inner side will be lined by the epithelial tissue. Yeah, look at the proximal convoluted tubule cell, epithelial cells, and look at the distal convoluted tubules, epithelial cell. Yeah, so this is the proximal convoluted tubule inner lining epithelium, and we are going to look at the distal convoluted tubule inner lining epithelium. Look at that, look at that. What is the big difference? Not at all, not much. But we have microvilli in the proximal convoluted tubule, and we have like minimum or no microvilli in the distal convoluted tubule. Hey, can I ask you guys, because I have been talking too much, can I ask one of you guys can answer for me, please? So what sort of cell is it? Sami or Alexandra?
Simple cuboidal?
Yeah, simple cuboidal epithelium. Look at that, very square cuboidal. Yeah, very square cuboidal. And of course, cuboid, as we know, the flat squamous epithelium, it doesn't work for any function, isn't it? If it is only one layer, it is for filtration. If it is multiple layer, like our skin, it is for protection. Like a very tall columnar epithelium, they are very abundant in the gastrointestinal tract. Their job is for absorption and secretion. They are busy cell type. Cuboidal, it is in between. Cuboidal will do like some of the, some of the columnar epithelium job. Yeah, they will secrete, they will reabsorb, and but not as busy as the columnar epithelium. So we have this cuboidal, simple cuboidal epithelium in our proximal convoluted tubule and distal convoluted tubule, which means we are going to absorb some of the proximal convoluted tubule filtration from the kidney, glomerulus come in. Then this proximal convoluted tubule or distal convoluted tubule will be going to reabsorb some or many of the filtrate, isn't it? It is lovely. So says the difference, the only difference is, yeah, they have microvilli and they do not have microvilli. And they are infolded plasma membrane. Look at the plasma membrane is highly infolded. It doesn't mention like that here. So don't worry, it is a small little thing, but what I want you to remember is proximal convoluted tubule, distal convoluted tubule, they are made of very square cells, which is cuboidal epithelium. Bang. Hey, how about the loop of Henle? Yeah, loop of Henle. So where is it? Loop of Henle. Loop of Henle is coming down, coming down, coming down, gradually going up, going up, going up, going up. So can I say this is descending, descending, coming down, and going up, ascending. So this is the descending limb of the descending limb of the loop of Henle, and going up, ascending limb of the loop of Henle. Yeah, loop, nephron, loop of Henle, Henle, loop of Henle. So if you're a little bit careful, if you look at the ascending limb, here is narrow and gradually large. So we will say this is the thin ascending loop of Henle, and this portion is called thick, fat. Of course, we should not say fat, it is thick, thick ascending loop of Henle. Yeah. So loop of Henle, now thick limb, here thin limb, thick limb. Yeah. So that is the loop of Henle, and let's go and look at the structure lining. Thin limb, of course, it is made of flat cells here, but thick limb, so might be made of the bigger cell, isn't it? It is a simple logic. So because why it is thin? Yeah, because the cell become flattened, therefore the whole structure collapsed, and therefore the whole limb became thin. So the thin descending and ascending limb is made of squamous epithelium. Yeah, so which means like if it is thin, this area is lined by the flat squamous epithelium, and thick ascending limb is same as the collecting deck or the distal convoluted tubule. Yeah, so thick limb, it is similar to the distal convoluted tubule or the collecting deck. So the thin descending limb or ascending limb is simple squamous epithelium. Thick ascending limb becomes same as the collecting deck. And the proximal portion of the distal loop of Henle is also the same as proximal convoluted tubule. So if the lining epithelium becomes so easy now, this proximal convoluted tubule, because or distal convoluted tubule, or the distal portion of the see this thick ascending limb or distal portion of the loop of Henle, they are all cuboidal epithelium. Only the thin portion, look at the thin portion, thin descending and thin ascending, is made of the flat cell. What a wonderful walk. It makes us simple. And cuboidal epithelium gradually change into columnar epithelium. And so this, in the collecting deck here, you can see the tube structure gradually bigger and bigger. You can see that this tube is bigger now because the cell became taller and taller. From here, cuboidal epithelium gradually became columnar epithelium here. That's what is written here. Cuboidal epithelium gradually changed into columnar epithelium, and in the collecting deck. So collecting deck start with the cuboidal epithelium, and then finally gradually become taller to become the columnar epithelium. And by doing so, becoming columnar epithelium, the cell size is taller, the cell height is taller, and the cell size is bigger, and their secretion and absorption function became more and more pronounced. And therefore, the diuretic hormone, antidiuretic hormone, is going to act on the collecting tubule. Right, so that is the epithelial lining of the renal tubule, which is made of proximal, loop of Henle, distal, and collecting deck. So let's go and dig around the renal capillaries. Yeah, so from the cortical radial artery, the afferent arteriole come out, and the afferent arteriole become the glomerular capillary. And here, look at that, afferent arteriole come from the cortical radiant artery, afferent arteriole come out, become the glomerular capillary inside the glomerular membrane, which is also glomerular capsule, which is also called Bowman's capsule, and leave the Bowman's capsule as the efferent arteriole. Hey, this is the afferent arteriole coming in, and this is the efferent arteriole going out. What is the difference? Can you see any difference between afferent arteriole and efferent arteriole? What is the difference? I'm listening. What is the difference between this afferent arteriole and what is the difference between efferent arteriole? Okay, if you don't want to talk to me, I will cry a little bit. Okay, so the size of the afferent arteriole, if you look at that, it is pretty big. Yeah, when you leave, this efferent arteriole is smaller. So this diagram, I think it is very good. It is trying to reflect the real life. The afferent arteriole is bigger and efferent arteriole is smaller. So what is the importance of that? The importance is that because the artery is, this inward is big, so more blood will come in, but the leaving route is narrow, so the less blood can go out. That means it will create a bit of pressure inside the glomerular capillary, which is for filtration. That is the beauty, you know, nature's beauty. And yes, of course, you know, efferent arteriole leave the glomerulus and then finally become the, well, you know, like arcuate artery, and then finally go back into the renal artery. And before they do that, they will loop around you can see them go and mesh around. They will go and mesh around the convoluted tubules here in the cortex. So these efferent arterioles, they are meshed with the proximal or distal convoluted tubules. That is what we call, because this, as we know, that this proximal convoluted tubule or distal convoluted tubule, they are in the cortex. Therefore, the arteriole, which is inside the, which is meshed around with the proximal and distal convoluted tubule, is called the peritubular capillaries. Yeah, peritubular capillaries, because they are close to the tubule, renal tubule, which is proximal convoluted tubule and distal convoluted tubule. And on the other hand, if you look at that, some of the afferent arteriole come in, efferent arteriole go out, and some of the arteries, they will just, you know, run around the loop of Henle. So they go down and they go up, they go down and they go up. So this capillary, because loop of Henle is straight, so these vessels become straight. Look at that, straight vessels, straight arterioles are straight, and therefore we will give them a name, vasa recta. Rectus massa, you have know that. Rectum, you know that. The definition of the rectum is straight, isn't it? So vasa recta, straight vessel, vasa recta. And the vessels makes a mesh around the tubules we will call peritubular capillaries. So yes, we have two types of capillaries, which is the efferent arteriole Some of the efferent arteriole will become peritubular capillaries. Some of the efferent arteriole will become the vasa recta. So yes, you know, and if you look at that, the nephron, if you look at this nephron is clear because if you the arcuate artery, this is the cortical medullary junction, this is the arcuate artery, and this is the cortical portion, this is the medullary portion. And this nephron, if you look at this nephron, it is mainly inside the cortex, and therefore we will call it cortical nephron. And if you look at this nephron, like with the afferent arteriole, glomerular capillary, efferent arteriole, and the glomerular capsule, convoluted tubules, they are closer to the corticomedullary junction, and therefore we will call it juxtamedullary. Juxta means close, very nearby, close to the juxtamedullary, so close to the medullary, juxtamedullary nephrons. So we have, like, fully cortical nephron is about 85%, and just medullary nephron is about 15% in our body. Yeah. So I hope you are following cortical nephron and juxtamedullary nephron. Juxta means close to the medulla. So if you look at that, corticomedullary junction is close here, therefore we will call it close to the medulla, juxtamedullary nephron. And you can see the arcuate artery and vein, and from arcuate artery, cortical radiant artery come out and deliver as the afferent arteriole, leave as the efferent arteriole. Some of the efferent arteriole will mesh with the renal tubule. Some of the efferent arteriole will run into the medulla, say vasa recta, and they will go out and back to the cortical radiate vein. Yeah, so I hope this diagram is look a little bit complex. If you see it, understand that it is not a big deal. Now let's go and look at this, like vasa recta. This is a vasa recta. If you look at that, it just extend along the renal pyramids down in the medulla, like following the loop of Henle. Look at the loop of Henle. It is running down, so the descending and ascending, and so because of the proximity, so closeness between the loop of Henle and the vasa recta, there might be some exchange between these two. So yes, the peritubular capillary, which we have talked about, and vasa recta, which we have talked about. And I am going to remind you again, peritubular capillary, because it is turn and twist and going around the tubule, their flow rate is low. And because these vasa recta, they are close to the loop of Henle for a long time. Look at that. And therefore, there must be some exchange between the loop of Henle and the vasa recta. So vasa recta will pick up some fluid back from the loop of Henle, and therefore makes the urine more concentrated. And peritubular capillaries, they are low pressure system because they are close to the proximal convoluted tubule, distal convoluted tubule, which are lined by the columnar epithelium, and therefore they will be exchanging with the distal convoluted tubule for the absorption and secretion. Yes, it is twist and turn, it is low pressure. So that is the way, it is cleverly created inside the nephron and around the nephron. And, therefore, this filtration kidney from the capillary into the Bowman's capsule and get to the proximal convoluted tubule. And when it is going out, the kidney will reabsorb about 99%. So if you filter 100 liters of urine from your blood into the kidney, 99% will be picked up by the body. So it's so clever. It's so clever, and it is so efficient because the size is not big at all. It is stacked in the posterior abdominal wall. And that is I want you to remember this 99% of the glomerular filtrate, which is the filtration from the glomerular capillary into the Bowman's capsule down into the proximal convoluted tubule. Hey, 99% will be reabsorbed once it leaves the kidney when it cut to the renal pelvis. So it is so amazing. This is the photographic, and they have to stay in the glomerulus and glomerular capillary and afferent at the arteriole. Where is the afferent arteriole? Here, afferent arteriole and the efferent arteriole. So I hope now you can appreciate the size. Afferent arteriole is bigger and efferent arteriole is smaller. By doing so, the smaller will create backward pressure inside the capillary. That way help with the filtration. Wow, wow, wow. Amazing, amazing, amazing. We haven't even think about that. So let's look at the renal corpuscle, which is made of glomerular capillary and the glomerular membrane, which is glomerular capsule or Bowman's capsule, glomerular capillary and Bowman's capsule, and they are afferent arteriole and efferent arteriole. Hey guys, which size is bigger? Afferent, efferent? Yeah, I want you to say afferent arteriole is bigger. No one talking to me this morning. So afferent arteriole is bigger, efferent arteriole is bigger. Yes, so now they have really worked hard to draw this diagram. And look at the afferent arteriole come into the Bowman's capsule and become the glomerular capillary and leave the glomerular capillary as efferent arteriole. And these arterioles, they are lying close to the proximal or distal convoluted tubule, or might be close to the loop of Henle, which is the early loop of Henle, or might be the more distal portion of the loop of Henle. And then now it became the proximal convoluted tubule, proximal tubule. And you now see the proximal tubules are square, which is the cuboidal epithelium with the little hair ciliated epithelium. Yeah, so now everything come back and match up together. And what we need to study is we need to study the area here close to the afferent arteriole, close to the efferent arteriole. We have the ascending and descending limb, or might be the proximal or distal convoluted tubule. And that is what they are calling the ascending limb of loop of Henle. So this is the cross section of the ascending limb of loop of Henle. And now we have to appreciate three cells, which are number one, macula densa, number two, mesangial cell outside the glomerulus, And number 3, granular cells. Hey, these names are a little bit awkward to remember. I cannot remember all the time. But if somebody say, I know what it is, and I know what we need to expect from this. Let's say if you're going for medical college or if you're planning for nursing, it is something you will have to remember at least for the exam, and you will forget it. That's what happened to me. I mean, when it comes to closer to the exam, I study that, and after a few weeks, I forgot that. But that's life. Like, so if you are going for nursing or if you're going for medical college, medical school, you have to remember that. You will forget it, that's for sure, and you will have to put it back in your head for the exam. You will forget about that again. So these 3 cells, now I want you to remember that they are macular densa, mesangial cell, and granulosa cell. So macular densa, where is it? It is from the cell of the loop of Henle, which is close to the afferent and efferent arteriole. That portion of the cell is called macular densa cell. And what is the granulosa cell? Granulosa cell exists on the wall of the afferent arteriole. Afferent arteriole, on the wall of the afferent arteriole, we do have granular cell. And look at the triangle they created. And there we have a cell there, which is called the extraglomerular, outside the glomerulus, mesangial cell. So these 3 cells, they are in combination called juxtaglomerular complex. Juxta means close, glomerular, close to the glomerulus, complex. Of course, if it is complex, it is not only 1, it is going to be 2. Yeah, so like macular densa cell, which is from the loop of Henle, ascending limb, going up limb, and extraglomerular mesangial cell, and the granular cell, which exists on the wall of the afferent arteriole. Yeah. And this is the glomerular capillaries, and now become the proximal tubule, which is lined by the columnar epithelium. So next slide, juxtaglomerular cells, juxtaglomerular complex, which is made of macular densa, granular cell, and mesangial cell, extraglomerular mesangial cell. Easy to start with, macular densa, which is from the ascending limb of loop of Henle. Macula densa from the ascending limb of loop of Henle. Cell of the distal convoluted tubule and the ascending limb of the loop of Henle. They act as a chemoreceptor, and they will monitor the solute concentration, so the fluid inside the tubules, filtration. They will check the hydrogen ion, sodium, potassium, like especially hydrogen ion. They act as a chemoreceptor. And then if something goes wrong, they will stimulate the granular cell. It doesn't do anything on its own. It will ask the granular cell. So it will, if something go wrong, if it is too much pH or too little pH, this way stimulate the granular cell to secrete renin. So now, because of the chemoreceptor function of the macula densa, this granular cell will have to secrete renin. Yeah, so it stimulates the granular cell to secrete renin. It's on its own, it doesn't do anything. It will stimulate the granular cell to secrete renin. So the extraglomerular cell, what is the job of it? It acts with the macular denser cell or granular cell. So this is the job of the juxtaglomerular cell. Okay, I will give you a few minutes break. Just before I let you go, can I keep you like 2, 3, 4, 5 minutes? So let's look at this area. Now you can see the afferent arteriole going in. On the cell, on the wall of the afferent arteriole, we have the granular cells here. This granular cell will secrete renin. And then we have efferent arteriole here. Between the afferent arteriole, and the loop of Henle and distal convoluted tubule. On the distal convoluted tubule and loop of Henle, we have the macular denser cell, which will act as a chemoreceptor. And here we have the extraglomerular mesangial cell, which will interact between these macular denser and the granular cell, because it is just like it's like a broker in between these two cells. It might have contractile function, and this macular denser cell here will check on the hydrogen ion and will act as a chemoreceptor. And if there is anything, it will stimulate the granular cell to secrete renin. And that way start with the renin angiotensin aldosterone system. Okay, last one slide, guys, before I let you go. Renin angiotensin aldosterone system. It starts with the renin, which is from the granular cell of the kidney. Angiotensinogen is usually secreted from the liver if there is low blood pressure. If our blood pressure is low, the liver will secrete angiotensinogen. Angiotensinogen itself, which is secreted from the liver, it doesn't do much. It is really inert. But because of the low blood pressure, the granular cell will secrete renin, and that renin will act on the angiotensinogen and then start the process, renin angiotensin aldosterone, and final product will be aldosterone, which will be secreted from the adrenal gland, adrenal cortex. Oh my word, just before I let you go, I give you like a big information. So now go away, have a rest, go and have a coffee. So we were talking about nephron, and nephron is made of renal corpuscle and the tube. Renal corpuscle is made of the glomerular corpuscle or Bowman's glomerular capsule or Bowman's capsule, and the glomerular capillaries. The combination of both is called renal corpuscle here. And the tube is made of proximal convoluted tubule, loop of Henle, distal convoluted tubule, and the collecting tract. Proximal convoluted tubule, distal convoluted tubule, very similar. And the afferent arteriole come in, efferent arteriole go out. These afferent and efferent arteriole, they might be going around the tubule, which is what we call peritubular arteriole, or they might be going along with the loop of Henle in the medulla, which is called vasa recta. So that is what we talk about, yeah? So if you remember that, if you remember this clean diagram, efferent arteriole, glomerular renal corpuscle, and the proximal loop of Henle, distal convoluted tubule, and collecting tract. If you remember this diagram, I believe you know this diagram, yeah? So the afferent arteriole come in, glomerular capillary, efferent arteriole go out. Glomerular capillaries and the glomerular capsule combination is called renal corpuscle. And the efferent arteriole will be going around the proximal convoluted tubule, distal convoluted tubule, and many things. And that is because they are around the tubular structure. Therefore, we will call peritubular capillary. And find some of the capillaries will go along the loop of Henle deep into the medulla, and that is what we call vasa recta. Of course, finally they will go back into the cortical radiate vein. So that this anatomy, and if you look at the vasa recta anatomy, look at that, it just follow all along. It just all follow all along the long loop of Henle. So that is what's happening here. And when doing so, like all they became like efferent arteriole, capillary, efferent arteriole, and the distal convoluted tubule might be proximal convoluted tubule, or might be some part of the loop of Henle. We get close in this manner, and the cell portion, which is close to the afferent and efferent arteriole of the cell portion of the loop or the distal convoluted tubule, which is close to the afferent and efferent arteriole, this portion of the cell is called macula densa. And on the afferent arteriole, we have another cell, granular cell. And in this triangular area, it is filled with the mesangial cell. So now we know three cells: macula densa, mesangial cell, and the granular cell. Combination of these three cells is called juxtaglomerular complex. So, and the job of it is macula densa cell. It will act as a chemoreceptor, so hydrogen ion concentration inside the renal tubule. So if I go back, so if this macula densa cell will detect the fluid inside the tubular lumen, which is like secretion, filtrate of the plasma inside the kidney, which will finally become urine. That fluid hydrogen ion concentration and this macula densa will act as a chemoreceptor. And if there is any changes needed, then it will stimulate the granular cell here, granular cell to secrete renin. And by doing so, the renin start to come up and renin will kick off and start the renin angiotensin aldosterone process. So macula densa cell will act as a chemoreceptor, granular cell will secrete renin. And what is the job of extraglomerular cell? Well, okay, it acts as like a broker in between these two cells, and it might have a contractile function. Yeah. Whatever it is going to start the renin angiotensin aldosterone system process. So as we know, renin is secreted from the granular cell of the kidney. Angiotensinogen come from the liver. So when we have low blood pressure, hypotension, we will get the angiotensinogen from the liver. So the liver will secrete angiotensinogen, which itself doesn't do much. But if the renin act on the angiotensinogen, then the process will kick off. So now someone has low blood pressure, liver will secrete angiotensinogen. Because of the low blood pressure, there will be concentration changes in the renal tubular filtrate, and the macular denser cell will detect that and act as a chemoreceptor. Hey, there is something wrong. It will stimulate the granular cell to secrete renin. So the kidney will secrete renin because of the hypotension. Because of the hypotension, liver will secrete angiotensinogen, and the renin will convert angiotensinogen into angiotensin 1. And this angiotensin 1 will be converted to angiotensin 2 by the Lange's angiotensin converting enzyme and the kidney renal endothelium as well. So mainly from the Lange's ACE angiotensin converting enzyme. The ACE is usually from the Lange's, and that convert the angiotensin 1 to angiotensin 2. So angiotensin 2 is the potent, increase the sympathetic activity. Angiotensin 2 will go to the kidney tubules and reabsorb the sodium, salt, and water will follow. In exchange, sodium with potassium. And it will go to the adrenal gland cortex, will secrete aldosterone. That's why we said renin, angiotensin, aldosterone system. So aldosterone is for salt and water retention. And it will, the angiotensin 2 will continue to act on the arteries, arterioles, constrict the artery, vasoconstriction, blood vessel constriction, because of the angiotensin 2. And it will also go to the posterior kidney, a posterior pituitary, to secrete antidiuretic hormone, which will go and act on the collecting deck to reabsorb water from the collecting soil. Because we have low blood pressure, the body wants to control the blood pressure by bringing up all the fluid back from the kidney and squeezing the artery. And therefore, this angiotensin 2 is doing everything it can do. So look at this diagram. So renin angiotensin aldosterone system. I believe if you are doing physiology, you will have to study this renin angiotensin RAA system. And if you want to move on as a nursing student or medical student, you will have to know. So there is no way out not knowing this renin angiotensin aldosterone. So just take it. Just take it. So liver will produce angiotensinogen, and kidney will secrete renin. Renin will act on the angiotensin and change it to angiotensin 1. Angiotensin 1 will be converted to angiotensin 2 by the angiotensin converting enzyme ACE. That is the ACE, is what we use for the anti-hypertensive medication, ACE inhibitor, ACE inhibitor, ACE inhibitor. Everyone is on ACE inhibitor. Yeah. If I believe you guys might have your elder people at home, like your parents or your much older brother or your grandmother, grandparents, everyone, all the patients with high blood pressure, they are on ACE inhibitor. Well, not all the patients, nearly almost everyone. So that ACE inhibitor is the inhibit this angiotensin converting enzyme inhibitor, so that the angiotensin 2 cannot be formed from the angiotensin 1, and therefore reverse effect. So the arterial vasodilatation help with the kidney, and therefore, it tries to lower the blood pressure. So yes, like the ACE inhibitor, whoever invented this ACE inhibitor is doing well now, because the even from the cardiologists, American Cardiology Association, it is approved that, hey, every patient, this ACE inhibitor is beneficial, and therefore we need to use it. So ACE inhibitor is just like a peanuts. Everyone with the high blood pressure is taking ACE inhibitor. So that ACE inhibitor came from this ACE, which ACE inhibitor will inhibit the ACE, and by doing so, the angiotensin 1 cannot go to angiotensin 2. So this RA system is really important. It comes from the kidney. So hey, let's move on to a little bit easier topics. Like we will talk about the ureter. Ureter is a tubular structure which is carrying urine, which is formed in the kidney and carried down into the urinary bladder. It is about 10 inches long. Of course, there might be some variation depending on the height of the patient, isn't it? And it is running at the tip of the transverse process of the lumbar 2, 3, 4, 5. And it crossed the sacroiliac joint. It crossed the sacroiliac joint and enter obliquely from the back into the urinary bladder. So look at that. This is the contrast scan looking at the renal outline of the anatomy. If you can appreciate it, you can see the, like renal pelvis, renal medulla, and all the dye coming out from the kidney, going along the ureter, which is at the tip of the 2, 3, 4, 5 lumbar vertebra, and then it runs in front of the sacroiliac joint, and it's obliquely go into the urinary bladder, and now the urinary bladder is filled with the contrast urine. Yeah, so look at this diagram. It is really lovely. Look at that renal pelvis, which is a little bit dilated for me. This is the shadow of the kidney, left kidney, right kidney, ureter. Hey, lumbar tip of the transverse process of the lumbar 2, 3, 4, 5. Look at that. That's the beautiful anatomy which we have to appreciate, So if you do the cross section, get the ureter and look under the microscope, how many layers do you expect to have? Of course, if you don't know, say 3, isn't it? Say 3. So mucosal layer, mast cell layer, and adventitial layer. So what's the big deal about this? Mucosal layer, mast cell layer, and adventitial layer. Look at the mast cell layer, inner circular and outer longitudinal. Oh no. So hey, look at that. Longitudinal layer is more inside and might be circular layer is more outside. Oh, that's a difference here. That's the difference. What's going on here? Okay, and the lining of the lining epithelium, look at that. It is transitional epithelium. So transitional epithelium is rare outside of the urinary system. So transitional epithelium is rare outside of the urinary system. It is mainly present in the urinary system. And now we start seeing the ureter. Ureter is lined by the transitional epithelium. And of course, our urinary bladder will be lined by the transitional epithelium. What is the use of the transitional epithelium? As we know, transitional epithelium gradually change as a multiple layer. It is for waterproof, watertight container. So therefore, we use it for the urinary bladder. We use it for the ureter so that the urine cannot leak out. And it is stretchable. So if there is loss of urine, our bladder stretch out. If there is, after voiding, the bladder shrink again. So that's the cross section of the ureter. This is the ureter lumen. The lumen is lined by the transitional epithelium and mast cell layer and adventitial layer. So what about urinary bladder? Our bladder, the blood supply for the urinary bladder came from the vesical artery. Of course, bladder means vesicle, so vesical artery. So superior and inferior vesical artery, which is coming from the internal iliac artery. So internal iliac artery will give branch to the to the superior and inferior vesical artery for the bladder. And we know that it is the extraperitoneal structure outside of the peritoneum. It is not the intraperitoneal structure. It is like a dome shape, pyramid shape, but it is like upside down dome shape. Yeah. And ureters enter its posterior and lateral to the bladder. And here, a little bit important, anterior angle is called urachus. So is it really important? No, unless you are planning to work in the urology department. So let's say if you want to be a urologist or a renal physician, or the staff, nursing staff in the renal department, you should know the urachus. Other than that, you can forget about this name, urachus. But for anatomy student, I want you to make sure you have heard about that. Urachus, it is the anterior angle of the bladder. Posterior wall of the bladder is called trigone of the bladder, and it is supplied by the sympathetic and parasympathetic nerve. So the capacity of a urinary bladder is usually about 400, 500. 400, 500. So which means like that is the maximum capacity you can take. So if I ask you to, if I keep you here and you are not allowed to go anywhere, and if you want to wee, the maximum capacity you can take is 500 ml. And let's say, like a can of beer might be about 500 ml. So yeah, you can take it like that way. The neck of the bladder continue as the urethra, which is coming out. So I hope this bladder is not a thing for you. And now, why do I add this slide? It is not important at all. So therefore, it is not included in your slides. But I just want to show you the urachus, where so urachus is a urachus derived from the allantoids. Yeah, allantoid is the structure connecting the little fetus abdomen into the trophoblast. So that is the development of the urachus. So allantoids, look at the allantoids. It is connected to our belly when we were inside the womb, and it is going into the trophoblastic tissue, which is the placenta. So this allantoids finally gradually become fibrous strand, and it is called the urachus. So just want to let you know where urachus and allantoids, so that you have heard of it. So layer of the bladder inside out, how many layers do we have? 3. The epithelial layer, muscle layer, and outer adventitia layer. So epithelium, bladder epithelium is lined by the transitional epithelium, and of course, epithelial tissue will have to sit on the lamina propria, and muscle, detrusor muscle, which is the very thick muscle. And I hope you have heard about detrusor instability. Especially in ladies when they become like 40, 45, 50, 55, 60. So like in later their life, about like, especially around 50s, they tend to get detrusor instability. So what is do is this muscle just contract inappropriately, and this lady wants to go to restroom again and again, again and again, again and again, for no good reason, because this detrusor muscle is irritating them. So yes, we can give them a medication to settle down. And look at the epithelium of the urinary bladder, transitional epithelium. Yeah, it's transitional, it's gradually change. Transitional epithelium, of course, if it is an epithelium, it will lie on the loose connective tissue, which is called lamina propria. And yes, this is the muscle layer, this is the epithelial layer, and this is the cavity of the bladder, which will contain urine. So as I say, like everything has 3 layers. Like don't forget tunica intima, media, adventitia. Tunica intima is the simple epithelium, which is the flat cell, and therefore we will call endothelial cell, and outside mast layer, and outermost is adventitia layer or serosa layer. So yes, that's the only the gastrointestinal tract. This is just a reminder. We have mucosa, big sac mucosa layer, mast layer, and serosa. This is for the gastrointestinal tract as a reminder. So now just keep concentrating on the urinary bladder. Urinary bladder, look at that. This is a bladder epithelium, is transitional epithelium. It has got thick mast cell, which is called detrusor mast cell, outer adventitia layer here, and it is covered with the peritoneum. And don't forget, ureters from the left and ureter from the right came from the posterior and lateral aspect of the bladder going into the bladder. Look at the entrance here. This is the entrance of the ureter. Ureteric orifice coming into the urinary bladder. And this is where we call triangle, which is the base of the bladder. And here, that is the triangle, yeah? So 2 triangle here. So 2 ureteric orifice and go back and come down ureter. So that is the diamond-shaped area. This area is called triangle of the bladder. Look at that triangle. So one here, one here, one here. So that is a triangular triangle here. And male urethra, female urethra. Female urethra, as we know, it is short. It has to go through the mast layer, which is the external urethral sphincter. And now it will become the external urethral orifice. Male urethra, it has a long windy route. And it has to go through the prostate. So we say that prostatic urethra, it has to go through the mast layer. We say muscular portion or intermediate part of the urethra. And it has to go through the external genitalia penis, which is called the spongy part of the urinary, spongy part of the urethra. Yeah. So what will be the lining of the urethra? Of course, at the early stage, it is continuous. So there might be some transitional epithelium. And finally, it will become like columnar, pseudo-stratified columnar or cuboidal epithelium. Let's look at that. But at least now I feel you have seen the triangle of the bladder. So you opening of the ureter into the bladder, one here, one there, and the ureteric orifice, internal urethral sphincter. So that triangular area is called triangle. So now male lower urinary tract, which consists of urinary bladder and the prostatic urethra. So this portion is the inside the prostate. So therefore, this is the prostate gland, prostatic urethra, membranous urethra or intermediate portion of the urethra in the mast cell. And this is the spongy part of the male urethra. And this is the external urethra meatus. Yeah. So I believe you have seen this diagram already. Hey, look at that. Urachus. This is what I was talking about. It is the fibrous band, which is the remnant of the allantois. You saw where the allantois is. Its job when we were fetus, like 4 months old, this urachus is taking urine from the bladder out into the environment. So that is the male urethra. You remember the seminal vesicles. You remember the vas deferens. Combination of vas deferens and seminal vesicle makes the ejaculatory tract. Ejaculatory tract enters into the prostatic portion of the urethra. Hey, look at that. Everything come back together. Yeah, and this is the female lower urinary tract. Your lower urinary tract means from the bladder down outside. Upper urinary tract means kidney and ureter. So lower urinary tract includes urinary bladder and the short urethra. Urethra has to go through the muscle, which is the external urethral sphincter. And this is the external ureteric meatus, little opening. Yeah, okay. And the bladder is here extraperitoneal, and the pouch between the bladder and the uterus is called vesicle. Vesicle means bladder, uterus, vesico-uterine pouch. Yeah. So urethra, let's talk a little bit about urethra. Urethra is lined by the transition. Initially, of course, it is starting from the bladder, so it is becoming the transitional epithelium, and later it will become pseudo-stratified columnar epithelium. Hey, I have said again and again, columnar epithelium, they are tall epithelium, so they don't really need to be multiple layer. I can't remember any like stratified columnar. So there might be something, but I can't remember. But pseudo-stratified, they pretend to be multiple layer. Pseudo-stratified, or maybe stratified here. Stratified columnar epithelium. That is the lining of the urethra. And finally, they will become stratified squamous epithelium when it gets close to the outside external urethral meatus. Yeah, internal urethral sphincter, which is made of the detrusor muscle, external urethral meatus, which is made of the urogenital diaphragm. Urogenital diaphragm. So female urethra, yeah, female urethra is 1.5 inch. It's not long at all. So from outside towards the bladder, you have to travel only 1.5 inch. That is pretty short, and therefore it is not surprising females are more prone to get cystitis, yeah, infection in the bladder. And male urethra is about 8 inches long, prostatic, membranous, and so, and we all have the external urethral sphincter, orifice, and the external urethral sphincter, which is the voluntary control. Yeah, if the time is not appropriate, we just squeeze it with the external urethral sphincter. Internal urethral sphincter it is just for reflex, you know. So this is the male and female urethra. So the micturition reflex. So now our bladder is filled with urine, and bladder gets stretched. Detrusor muscles are getting stretched, and there will be stretch receptors here. And these stretch receptors will be taken to the inferior hypogastric plexus, and finally go into the pons here. Pons, so that's brainstem. Brainstem is made of midbrain, pons, medulla. So it will go to the pons. It has got pontine micturition center, and then come back down and go back to the bladder and just squeeze it out. Of course, we also have external sphincter, which we voluntarily control if it is not appropriate. Yeah. So pelvic nerve, the bladder gets stretched, go there, and then go to the pontine center, come back down, inferior hypogastric process, and then come back to the urinary bladder. So that is the micturition. So once you start wee, you can stop, because the reflex, you know, just these detrusor muscles start contracting and pushing away the urine out. So this is the micturition. It is autonomic nervous system, so autonomic reflex nervous system, and the somatic mean, which is the voluntary control. The parasympathetic and sympathetic nervous system will stop the micturition. So if you are frightened, if you are under stress, the sympathetic nervous system will dominate, and you are trying to control. You don't want to wee. If you are a little bit relaxed, then the parasympathetic nervous system will kick in, and that will stimulate the urination. So now, near end of the lecture, we will talk a little bit about how did we get the kidneys. So when we were babies, we will have like babies mean, when we are in the mother's womb, like when we were fetus stage, we will start to have a pronephros. Pro mean yes, nephros mean kidney. Pro mean yes, early stage. Pronephros gradually degenerate, just disappear, gone. And then we have another little buds on each side. That is what we call mesonephros. That will degenerate. And finally, we got metanephros. Meta, that will become kidney. Do you really need to know this? Not really. It is something for knowledge, so that if somebody says something, at least you feel like, hey, I have heard about this. So pronephros, mesonephros, they will degenerate. And finally, our adult kidneys, they arise from the metanephros. And allantoids, I believe you have seen allantoids, which will become uric acid of the bladder. Uric acid is nothing more than the fibrous tissue going from the bladder to the anterior abdominal wall. And urogenital sinus will develop into bladder and urethra. And I want you to remember kidneys, when they were early stage, they were in the pelvis, and the pelvic kidney will have to go upwards. That is what we call ascending of the kidney. So look at that, look at that, look at that. Where is this is the little fetus stage, this is the head portion, this is the tail portion. And look at the mesonephric duct, pronephric duct, mesonephric duct. They will all degenerate. Yeah, only the metanephric duct. Hey, metanephros. Look at the metanephros. It comes really close to the tail end, and then finally it will have to go up to the thoracic and lumbar junction. That is what we call ascent of the kidney. And if you look at that, this little kidney, which initially developed at the very tail end, so at the fetus stage, and finally it is moving upwards because this body is prolonging distally, and finally it's just going up and up and up and get to the thoracolumbar junction, T11, 12, lumbar 1, 2, 3 region. It initially was from the pelvic organ. So what can go wrong? Of course, many can go wrong. Many different things can go wrong. When the kidney is coming from the pelvis to the abdomen, and initially, two kidneys are fused together as one, and finally split into two. And let's say if the split is not, if there is no split, then that is what we call horseshoe kidney. The kidney shape is becoming like a horseshoe because they are fused in the inferior pole. Actually, this pole need to gradually get separated and we will have two kidneys. But now we are having one big kidney. Of course, we have the inferior mesenteric artery in the lower part. So this horseshoe is going to get blocked with the inferior mesenteric artery, and it cannot come up into the abdomen. Then thus become the pelvic kidney, which is the horseshoe-shaped kidney. Of course, many different blood supplying different can go wrong as well. So, two kidney being separated, but their blood flow is a little bit different. So yes, we have to appreciate the different possibilities of our kidney during the development when we were fetus life. So let's say if we have a normal kidney, it is a blessing. Yeah, it is a really, really, really blessing, guys, because there are a few people who has to live with this sort of kidney, like in the pelvic organ. What sort of life it is? Yeah, you don't even have a normal life when you are born with. So this is the histology slide of the nephron. I believe you guys saw this slide when we talk about the epithelium, like this is the tubular portion, this is the glomerular portion. And don't forget about this ureter, which is running at the tip of the transverse process of the tip of the transverse process of the limb 2, 3, 4, 5. And this is the renal outline. Right, let's come to the end of the urinary system. Has anyone got any question about this? I hope it is a lot. I hope it is a lot. I appreciate that. I want you to go through the textbook or the lecture slides again, so that you all can remember. Any question? Okay, then. If not, I'm going to introduce you to the muscles of the back. So that will not take long. That won't take long. I'm going to stop sharing the slide, and then I will share you the muscles of the back. Okay, guys, so muscles of the back, yeah, our back posterior abdominal wall muscle. So we keep it a little bit lighthearted. Don't take it too serious today. It is just an introduction. If possible, I will repeat that when we on Friday lecture. So this is, we're going to talk about muscles of the back. These are the muscles we are going to talk about. Hey, look at that, guys. What a beautiful muscles there. Yeah, so look at that. So if anyone can MU and scream and shout, and what sort of muscle it is. Yeah. Hey, what is this muscle, guys? That's muscle in the buttock, which is the gluteus muscle. Yeah, gluteus muscle, buttock muscle here. Hey, what is this muscle, guys? That is the deltoid muscle, isn't it? What about this big triangular muscle? It is trapezius, isn't it? Now you can see the big broad muscle here, going from here, there, going from here, there. What is it? That's the latissimus dorsi. Yeah, so trapezius, latissimus dorsi, and this must be the tricep muscle, which is in the back of the arm, and this is the back of the buttock, which is the gluteus maximus muscle. And you can see the muscle which is in the back of the thigh, which we call hamstring muscle, and muscles of the calf, which we call gastrocnemius, lateral gastrocnemius, and medial gastrocnemius. Beautiful, isn't it? Such a big bumpy muscles on the back. But if we take the skin off, that's what we have. So we have the trapezius muscle. We have the trapezius muscle. We have the latissimus dorsi muscle. Latissimus dorsi, more in the center, we have the lumbar fascia. So this muscle became fascia, thick aponeurosis, connective tissue. I believe you know the fascia. So this is what we call the lumbar fascia. And look at this gluteus maximus muscle, which we saw. Look at that. This muscle stripes are striping here. You can see that this gluteus muscle stripes are there. It is beautiful. It is beautiful, guys. The trapezius, latissimus dorsi, and the gluteus maximus. Yeah, of course, this is in the central portion, we have the lumbar fascia. Of course, in a cadaver, This is what we see, latissimus dorsi. This is the trapezius at the top, and the lumbar fascia, thoracolumbar fascia. So that is what we see here, and we can see the gluteus maximus. Bang. Muscles of the back. So we group into extrinsic muscles and intrinsic muscles. So because there are small little tiny muscles here and there, so we are a generalist. We can see from the bird eyes point of view, we're just superior, we stand above everything, and we are going to see in a clever way. We would split the muscles in the back into extrinsic muscles and intrinsic muscles. What is the difference between extrinsic muscle and intrinsic muscle? Extrinsic muscle, they will connect the back to the upper limb or the chest, respiration. So for movement of the upper limb and respiration, these muscles are called extrinsic muscle, and intrinsic muscle is just for the back itself, just for the vertebral column itself. It's just act on the vertebral column. Hey, life become a little bit more meaningful, yeah? So muscles of the back can be divided into extrinsic muscle of the back and intrinsic muscle of the back. What is the difference? Intrinsic means it's only act on the spine. These are the muscles for the spine, spinal muscles. Extrinsic muscle of the back, they communicate the back spine with the upper limb. They communicate spine with the chest, thoracic wall, respiration. So these extrinsic muscle and intrinsic muscles we do have in the back. So muscles of the back can be extrinsic muscle or intrinsic muscle. For the extrinsic muscle, we can divide into 3 layers: first layer, second layer, third layer. If you don't know something, say 3. Yeah, say 3 if you don't know something. So extrinsic muscles we would divide into 3 layers, and intrinsic muscles we divide into another 3 layers. First layer, second layer, third layer. Wow, easy. Okay, so I'm going to stop here. That is the introduction for the muscles of the back. And don't forget, I don't expect you to remember all these muscles in detail. But let's say if somebody asks you, let's say, a student from another anatomy class, come and challenge you. Hey, do you remember the muscles for the back? Yes, I do. I remember as a extrinsic muscle of the back and intrinsic muscle of the back. Oh, what does it mean? Intrinsic muscle means it will act only on the spine. Extrinsic muscle, they will relate the spine to the, they will relate the back to the thoracic wall for respiration. They will relate the muscle from the back to the upper limb. Hey, that student, we shut up. Yeah, okay.